Thank you for inviting me to give this presentation. I will be talking about C. diff, the epidemiology, risk factors, pathophysiology, and everything that you need to know. My name is Dr. Brooke Decker. I work at the National Institutes of Health as the director of the Hospital Epidemiology Service, and I am boarded in critical care and infectious diseases. First, I'm going to start off with a few basics. Taxonomy. The name did change recently, and I want you to be aware that Clostridioides is now the appropriate genus, and it's not as hard to say as it looks. You can still say C. diff, which is a very useful thing that the taxonomists decided instead of classifying as Peptoclostridium, when they found that it more closely resembled Peptostreptococciae, they decided to save you the hassle, keep the C. diff. And this is something that now you know. Infection, you may very well be aware that C. diff colonizes the large intestine of humans, but it also colonizes other mammals, both wild and domestic, which means that pets could harbor C. diff, and the beef industry, which uses quite a bit of antibiotics, could also be a source that may not be something that is commonly thought of. People can be animals can be colonized by toxigenic and non-toxigenic strains. We typically think about the toxigenic strains because they cause the disease. That is almost always including toxin B. They may or may not have toxin A, and there's also binary toxin, which is one of the toxins that is less commonly discussed. How do you get infected? Well, the toxins inactivate your Rho GTPase, which causes actin depolymerization, which can cause cell death. The cell death and inflammation, which results in diarrhea in the colon and pseudomembranous colitis, as we see. This may not be something that you've heard before, but I'm going to tell it to you because I am a hospital epidemiologist and we report C. diff infections to the NHSN. The CDC lab ID surveillance definition for infection is here. So there needs to be diarrhea greater than 3 unformed stools on the 3rd day after admission or within 4 weeks from discharge. Operationally, this could be someone who comes in with diarrhea, but no one tested or reported on it until the 3rd day of admission. And then that would be recorded as a hospital-associated case, which would go on the data that your hospital is compared to other hospitals for quality. This is very important to be aware of because the clinical definition, which we typically think of as clinicians, does not always line up with the surveillance definition, but the surveillance definition is what your hospital is graded on, regardless of if it makes clinical sense. So being aware that your patient who comes in with diarrhea should be tested before that 3rd day to rule out C. diff before it gets attributed to your hospital is critical information for everyone to know. And it's reported in the number of patient days, which means the number of patient days in your hospital, and then how many cases of hospital-associated C. diff are identified. Another critical thing to know is how does your lab test for C. diff? You may interpret a positive test differently if you know that your hospital is sending every stool that comes to the lab for a PCR or a nucleic acid test. That is a very sensitive way to test for C. diff colonization. You need the clinical information to know if they truly have an infection. Now, the surveillance definition, as we previously discussed, is going to be completely agnostic to what's clinically going on with the patient potentially, but you as the clinician should know whether you are potentially overdiagnosing in your hospital or potentially underdiagnosing if only the toxin is being sent. Most places these days are either using only the PCR, which would possibly result in overdiagnosis, or a combination test, which may be more accurate and more likely to be what's truly going on. That being said, the 2-step tests do have pitfalls as well, which means you could miss someone who truly has disease depending on the 2-step test you have. So it's important to know what test your hospital is doing and be prepared to adjust how you are treating the patient or seeing the patient based on what you know about your test type. So now I'm going to talk about C. diff infection and how we can stop and prevent this chain. So a patient with some risk may become colonized, and then they could develop infection after some inciting factor. So what are some risk factors for asymptomatic colonization? The first step before you get sick. A really nice meta-analysis looked at this in great detail. There are a lot of studies out there now. They summarize that hospitalization in the last 6 months does appear to be associated. Use of gastric acid suppression in the last 8 weeks, tube feeding, corticosteroid use in the last 8 weeks, and antibiotic use was not associated with colonization, and we'll get to that in a moment. So risk factors for infection, separate from colonization, probably requires colonization to get there. A different meta-analysis looked at infection risk factors as advanced age, and here we call that over 65, hospitalization, use of antibiotics, and very specifically, the antibiotics clindamycin, broad-spectrum penicillins, cephalosporins, and fluoroquinolones. Broad spectrum penicillins may not be as broad as when you think about broad spectrum antibiotics. That includes ampicillin and amoxicillin, and of course, piperacillin, the component in Zosyn. So first, let's talk about stopping patients going between having risk factors and becoming colonized. The main way to prevent that from happening is good hand hygiene. Healthcare worker hands have been shown to be associated with transmission of all varieties of infection. And there's good data to show the compliance, which is observed compliance of people washing their hands before they enter and exit patient rooms, is inversely associated with C. diff infection. Compliance with glove wearing in patients who require contact precautions typically is good when we observe these activities, but what we don't see and what is an opportunity for improvement is whenever you remove gloves from your hands, you should be washing your hands at that time. Sometimes maybe between 5 to 10% of the times you take your gloves off, you are actually contaminating your hands with what was on the surface of your gloves. If you don't wash your hands after removing gloves, you may transmit that or bring it on your lunch break or to the next patient. So soap and water hand hygiene, which is recommended in cases of C. diff, specifically because the spores with C. diff may persist after alcohol sanitizer rub. They're not going to be inactivated by that. You need to mechanically remove them from your hands, flush them down the sink to get them off. So if you need to use soap and water because your patient has diarrhea, you suspect or you've confirmed C. diff, you should be finding a sink. There was a study showing fairly obviously that if a sink is visible from the patient's door, then you're more likely to do that soap and water hand hygiene. And that may be another opportunity for hospitals to improve compliance and reduce C. diff rates, is to ensure that there's sinks available to do soap and water hand hygiene. Environmental persistence. This is another way, other than healthcare worker hands, that patients could acquire C. diff. That C. diff is, the spores again are not killed by common disinfecting agents, specifically quaternary ammonium and alcohol that we may use, but we can kill it with bleach, a sufficient concentration of peroxide, and any agent that you're using to disinfect will have on it a what it can be used for, as in if it's sporicidal, it will state that. It will also give you the amount of time that it would need to be present on the surface to successfully deactivate spores. You need to follow that information in order to make sure your surface is adequately disinfected. Of course, the agents that are more likely to kill spores or sporicidal are going to be more reactive. That means they can damage surfaces. Depending on the type of surface or the type of item you're cleaning, it could cause more wear and tear. Some products do not recommend sporicidal disinfectants, which becomes a bit of an issue because if you use them in healthcare, you're going to need to be able to decontaminate them. Hospital cleaning, you may not think about this, perhaps you do quite a bit, but the floors are not often disinfected with something sporicidal. Stool can get on the floor. Your patient may drop their cell phone, pick up their cell phone, and then become contaminated with what had been on the floor with the prior patient. This is also something to keep in mind. If anything touches the floor in the hospital, it should be discarded or disinfected with bleach to ensure that there are no C. diff spores that have been transmitted. UV light is another application that kills spores that we've been using quite a bit in my hospital, but it has some pitfalls, which means it has to have the appropriate amount of contact time, and the equipment can be delicate and hard to transport. and expensive. Think of all reusable medical equipment as potentially contaminated during patient care. That includes your stethoscope. It should be cleaned between every patient use, and anything that you contact or contacts the patient during the exam could be a source of contamination. So anything you're bringing with you in the patient exam, especially in a case of C. diff, but also in other patients who you don't know that they don't have C. diff, make sure that you're decontaminating. So colonization on admission, I've just told you all these ways to prevent someone from getting colonized, but some patients may arrive to you with C. diff. They could work in agriculture, they could have been in another hospital. It is possible that community sites, patients could acquire C. diff at this point, not necessarily the hospital. And when we've studied healthy, unhospitalized adults, we found that a certain number of them do carry C. diff. So the last thing that we could try and prevent is, if you have a colonized patient, how do we keep them from getting infected? And my advice here would be to only give them the antibiotics they need. We work in healthcare, our patients are going to need antibiotics, but what we can do is give them the right antibiotic for the shortest period of time that is effective for what they need the antibiotic for. And specifically cephalosporins, which we know are associated with C. diff, are something we commonly use in perioperative prophylaxis. Perioperative antibiotic guidelines typically only recommend 1 dose, at most maybe 24 hours for almost all surgeries. And it is reassuring sometimes to know that your patient is on antibiotics, but you don't want it to be at risk of the patient getting C. diff. Lastly, a summary slide of what we can do to succeed. Please make sure you wear your appropriate PPE, the gown, gloves, if you're going to see a patient who may have C. diff. Follow your hospital policy. Wash your hands after you remove your gloves, and wash them with soap and water when you're seeing a C. diff patient. Ensure all of your reusable medical equipment, including your stethoscope, is cleaned with a sporicidal agent if you expose it to someone who may have C. diff. And use antibiotics judiciously, the narrowest appropriate agent for the shortest effective period of time. Thank you.